Welcome everyone to today's session of our Neuro-Oncology Wellness Series. We will be learning about glioblastomas in this session, which is moderated by Dr. Gonzalez Castro and led by Dr. Reardon. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session. At the end of this session, your questions in the chat or the Q&A will be used to moderate a brief question and answer. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center, or you can email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Gonzalez Castro.
Thank you so much, Rebecca, for the introduction, and welcome everyone to our second Education Now webinar for a discussion on glioblastoma with its current and future therapies, hosting David Reardon, and I'll introduce David in just a minute, but I wanted to take 1 minute only to talk to you about the Neuro-Oncology Wellness Program, which is a new initiative of the Center for Neuro-Oncology here at Dana-Farber, where we're trying to support our patients beyond clinic visits through offerings that increase our patients' awareness of their disease and their symptoms, as well as empowering our patients with ways to manage their symptoms and stay healthy throughout the course of the disease. So with this purpose in mind is that we have organized a series of webinars. We had our inaugural webinar last month on brain tumor symptoms. We're going to be talking about glioblastoma, and the subsequent webinars will be focused on specific diseases that we treat here at the Center for Neuro-Oncology. The next one in August will be on IDH mutant gliomas, and there will be a discussion with me and Dr. Gilbert Youssef. So we'll be sharing the calendar with you through subsequent emails, and if you haven't joined our email list, I encourage you to do so. There will be 2 surveys today at the end of our presentation. One that Rebecca will post, and then there'll be another one where you will be able to enter your contact information to join our email list. Without further delay, I would like to introduce my colleague and friend, Dr. David Reardon, who has graciously agreed to spend time with us today talking about glioblastoma. Dr. David Reardon is the clinical director of the Center for Neuro-Oncology at the Dana-Farber Cancer Institute, and he's a professor of medicine at Harvard Medical School. He is the recipient of numerous awards for his research and clinical care, and he is the past president of the Society for Neuro-Oncology, which is the main society, worldwide society that involves all professionals caring for patients with brain tumors. He has been caring for brain tumor patients for over 25 years, first at Duke University, and over a decade now here at Dana-Farber. And his research career has been devoted to finding more effective treatments for patients with primary brain tumors, including glioblastoma. As many of you know, he has led multiple clinical trials evaluating immunotherapy and other therapies for the treatment of glioblastoma. And within immunotherapy, he has led trials evaluating immune checkpoint inhibitors and cancer vaccines, which we'll be talking about later today as part of the webinar. David, thank you so much for joining us today.
My pleasure, Nick. Hello, everybody. Welcome.
So let's get right into it. Last month we had a general discussion on brain tumor symptoms, and today, as I mentioned, is the first disease-specific webinar. Can you give us an overview of glioblastoma, just to kind of lead us into the topic? What is this type of tumor? How common is it? And who is most commonly affected?
Yeah, I think it's very important to set the stage here for what we're talking about. And the reason we included it in this webinar and made it so early in the course of these webinars is because it is the most common type of cancer that arises in the brain in adult patients. We'll be talking about many other different types of cancers involving the brain and spinal cord, as Dr. Gonzalez Castro mentioned in future webinars. But this being the most common one, we thought it was appropriate to begin the series on these specific cancers focusing on glioblastoma. There are approximately 13,000 cases diagnosed in the United States each year. Glioblastoma is a cancer that starts in the nervous system in the brain or the spinal cord, mostly in the brain. It arises from the supporting architecture of the brain called the glia. If we think of our brain in two kind of simple structural components, the glia is the part of the brain that gives the supporting definition, the architectural support of the brain, kind of like the framework of a house, if you will. And that's where most cancers that arise in the brain come from, these cells of origin, the supporting architecture of the glia. The less aggressive, slower growing components or members of this family are the lower grade tumors, the grade 2 and the grade 3. The most aggressive and highest grade, by definition, according to the World Health Organization classification system, are the grade 4 tumors, with glioblastoma being the most common type. This is a type of cancer that can happen at any age. Unfortunately, I've taken care of infants and young children, but it does increase in frequency as we get older. And the most common age that glioblastoma affects individuals is in the 6th to 7th decade of life. Like most aggressive cancers, it's more common in men than women, modestly more common in men than women. There are certainly many women who are affected as well, but probably about 60% in males and 40 to 45% in females. A lot of research going on trying to understand why this type of cancer arises in the brain. There's a lot of research ongoing looking at environmental factors, things that we are exposed to every day in our life, chemicals, occupational exposures, infection, head trauma, cell phones. There's a lot in the lay press about cell phones. The only factor that's been linked with an increased risk of the development of glioblastoma from an environmental exposure is data implicating therapeutic radiation to the head or scalp. And people have undergone therapeutic radiation to the head for a variety of different reasons over over years historically. It's not X-rays, it's not exposure that we may have from a CAT scan. It's a higher dose of radiation administered therapeutically. And unfortunately, the data has shown, analyzing thousands of patients over many years of history, that those who have had this type of exposure have a small but increased risk of this type of cancer. The vast majority of our patients don't have any exposure to therapeutic radiation. So for those patients, there is nothing that they didn't do that caused this to happen. There isn't something they ate or an environmental exposure, and certainly not with cell phone use, that we can implicate an increased risk of this type of cancer.
Thank you so much for clarifying that. And a related question that often comes up in clinic is, someone receives a diagnosis and comes to us for a consultation, and they ask, are my children at risk, or are there any other family members at risk? Is this a disease that runs in families?
That's a very important point, and for the vast majority of patients, there does not seem to be a genetic or inherited link. There are small infrequent cancer predisposition syndromes where many different types of cancers run, unfortunately, rampant in families related to a gene that has a mutation or an abnormality that increases the risk of cancer in general in those unfortunate families. these are not subtle. These are families where cancer affects multiple generations, young family members, middle age, and older family members. And there are usually a variety of different types of cancer that can include brain tumors. Fortunately, those genetically inherited cancer predisposition syndromes are pretty rare and infrequent. And again, the vast majority of our patients don't have any family member that has had this type of cancer. And the studies that have been done show that the risk of an immediate family member, one of our patients whose brothers or sisters or their children, this type of cancer developing in them, is essentially that of the general population. There really is no significant increased risk in immediate family members. So I always emphasize and make that point when dealing with a newly diagnosed patient, that they don't have to worry that there's an increased risk of their brothers or sisters or their children having to undergo such a diagnosis as well.
Thank you, David, for discussing that and clarifying that for our viewers. I thought that it would be appropriate just to walk our viewers through the whole process of how patients present and are diagnosed and how treatments are discussed. So last month, we discussed that brain tumor patients often present with seizures or focal neurologic deficits or headache. They come to the emergency department often, and an image is done of their brain that shows a lesion. And what are then the next steps? How is the diagnosis of glioblastoma formally established after something is seen on an MRI of the brain?
Yeah, usually in this situation, patients come to medical attention fairly quickly because of this member of a family of related cancers that arise in the brain. The grade 4 members, the most aggressive members, including glioblastoma, do tend to grow rapidly and lead to symptoms that develop usually over days to a few weeks. Patients will come in and present. Often they'll have an initial CAT scan done to try to rule out an acute hemorrhage or stroke or other neurologic issue that could cause similarly rapid onset of neurologic deficits or symptoms. But ultimately, an MRI is most helpful. And on the MRI, we can see fairly typical features of glioblastoma. Many cases are quote unquote textbook, where they have characteristic features on an MRI scan. Some of them are a bit more subtle, but most of them have fairly characteristic features on an MRI scan. And this clinical presentation plus those MRI findings typically warrant a rapid referral to a neurosurgeon. And the neurosurgeon's critical question is, can I safely resect this or remove it, or at least biopsy it so we can know exactly what we're dealing with? And that procedure, that neurosurgical intervention, either resection and analysis under the microscope of what's removed, or biopsy and a similar analysis, is the definitive way a diagnosis is made.
If a tumor is close to the surface of the brain and readily accessible by surgery, and a surgeon can go in and resect what they see, can that lead to complete eradication of the tumor?
An effective and safe resection is a critical part of the treatment of these tumors, but unfortunately that by itself is not sufficient. If only surgery is done, this tumor will ultimately come back, and often, unfortunately, in a matter of weeks to a few months. And the reason for that is that although this is a cancer that arises in the brain, for reasons we don't understand, it does not metastasize. In the 30 years I've been involved in neuro-oncology, I've maybe had only a couple of cases, less than a handful, where we've actually seen this type of cancer spread elsewhere in the body. It arises in the brain and tends to stay in the brain. And what it does, instead of metastasizing outside of the brain, is that it infiltrates and spreads microscopically with cells moving out almost like tentacles. One analogy I've heard people describe this process with is like weeds in a garden, where the little microscopic cells can move outward and they blend right in with the adjacent brain. And even with the state-of-the-art technology we have with MRI scanners, which are incredibly detailed and sensitive, and with all of the tools in the operating room and technology neurosurgeons have now at their disposal to critically evaluate the extent of the tumor, these leading edge cells that are migrating outward and blending right in with the normal brain cannot be picked up and readily identified, and for that reason can't be removed. So removing the main mass of the tumor is a critical part, the part that we can see with the MRI scan. But unfortunately, these microscopic cells that are left behind unavoidably, even within the best of hands, limit how durable a benefit from a surgery can be. It's a critical, important first step to remove as much of the tumor as can safely be done. And it really should be done at a center where they have expertise and excellence and state-of-the-art technology. But in and of itself, unfortunately, it's not enough, and further treatment will have to be administered.
Exactly. Thank you for clarifying that, surgery is indeed the first step. It helps us establish a diagnosis. And, the more that the surgeon can remove, the better it will serve the patient's goals. But additional treatments are required. And why don't we go ahead and discuss now what are those treatments that we often discuss with our patients based on, standard therapies that have been evaluated and have been shown to have a benefit for this disease?
Yeah, the standard of care after a maximum safe surgery is a combination of radiation therapy, very carefully administered using state-of-the-art computer programs to administer therapeutic doses of radiation to the perimeter of the surgical margin. And that's combined with an orally administered chemotherapy drug called temozolomide or Temodar. Several years ago, the only treatment we had after surgery was done was radiation therapy. And in the early 2000s, a study was done showing that adding this chemotherapy drug, temozolomide, to radiation therapy could enhance the benefit of the effective radiation therapy. I kind of think of them like a 1-2 punch, where the two of them can have more of an effect than either one alone. So our current standard of care after a maximum safe surgery is to combine radiation, usually given over 6 weeks, Monday through Friday, 5 days a week, 6 weeks, roughly 30 doses, combined with a daily dose of the oral chemotherapy drug temozolomide. And then that's typically followed by 6 additional months where the oral chemotherapy drug is given by itself 5 days in a row each month.
Excellent. One finding that is often reported in pathology reports and is a default finding that we describe in our pathology reports is something called MGMT gene promoter methylation status. What is the relevance of that molecular finding to what we can expect of standard therapies?
Yeah, the MGMT test, methylguanine methyltransferase, is a test that's routinely done in order to help predict the likelihood the tumor will be sensitive to the chemotherapy drug. This test has been done in many ways over decades now and has been certainly refined, but it's a general predictor. It gives us a ballpark guesstimate of how likely the tumor will be sensitive to the chemotherapy drug. About a third of patients, 35 to 40%, it's what's called favorable, where the promoter is methylated. And that means there's a higher predicted likelihood that tumor cells will be more sensitive to the chemotherapy drug. And in about 60% or so, it's what I refer to as unfavorable or unmethylated. And that means simply that there's a higher amount of this protein present within the tumor, and that predicts a lower likelihood of benefit from the chemotherapy drug. But it's really, really, really critical to understand that this is a predictor. It's not a perfect test. And there, you and I have many patients where we've seen the MGMT predictor be unfavorable, and they're responding very well 2-3 more years down the road, and the tumor hasn't come back, and they've done quite well. And then on the flip side, we've had patients where the MGMT test is favorable, and unfortunately, 2 or 3 months into treatment, and the tumor's not responding. So it's a general predictor, but it's not a perfect one. And at the moment, we do utilize it to have this important insight. But we still recommend the inclusion of the current standard of care with the temozolomide chemotherapy, even if the test predicts unfavorability, because it's not a perfect test. And most importantly, because we are working very hard to identify better treatments, but so far have not identified one that's superior to the current standard with the temozolomide chemotherapy, even for the MGMT unfavorable patients.
Thank you. Thank you for explaining that so well. It's a confusing thing for many of our patients, and they see that on the pathology report, and they often wonder, what the significance of it is. Another treatment that has come up in the recent years, and we discuss with our patients as well, is something called tumor treating fields. Can you take a few minutes to walk our patients through what that treatment involves, and what is it that we can expect out of it?
Yeah, the tumor treating fields, or the Optune device, is an FDA-approved device, and it's approved for brain cancer. A similar application was not long ago approved for a form of lung cancer called mesothelioma. And there are ongoing studies looking at similar devices for other types of cancer that are looking promising. So this entity, this treatment, does seem to be having some benefit across a spectrum of different cancers. And what it boils down to is it's a device that's applied to the body, and it generates a very high frequency oscillating electrical field. Patients don't feel anything, but it's happening at a microscopic level within the tumor microenvironment that the device covers. And when there's that kind of a very high frequency oscillating electrical field, very elegant work done in the laboratory many years ago showed that cancer cells struggle to divide and to grow in those conditions, and many of them give up and die. And that observation led to the development of this device as a therapeutic strategy to exploit that potential weakness. As one could imagine, it's pretty challenging to come up with a device where you can apply this to a brain tumor. But that's what the company that led to the development of the tumor treating fields did. It's a device that's applied directly to the scalp with 4 pads, one on the left, one on the right, one in the front, one on the back. Patients have to shave their head every day, so the pads are directly applied to the scalp. And each pad is connected by a small wire to about a 3-pound battery pack. And when those wires are connected and the device is turned on, again, patients don't feel anything, but the electric field is happening between those pads, going from left to right and front to back. And a randomized trial of over 700 patients, where patients used the device or they didn't, half did, half didn't. Those that use the device on a daily basis, and they have to use it, have it turned on for about 6 months with the chemotherapy, and a minimum of 15 to 16 hours a day. So it's a pretty continuous exposure that has to be applied for it to work effectively. The patients who used the device, compared to those who didn't, did live longer and had a modest, not a home run, but a modest improvement in survival. Interestingly, the patients who had the favorable MGMT test, the one that predicts a higher likelihood of benefit from the chemo, seem to have a higher benefit from this device as well. And it suggests that the chemo and the Optune device may be able to work additively or in a combinatorial way to make each other work better than either one alone. The device is a challenge, and it's, to be honest, many of our patients opt not to do it because they don't want to have this thing on their head and turned on for many hours a day for several months. And the benefit it provides is modest. It's not a home run. So it's a balance and made on a very individual patient and family basis if it's worth going through that and putting up with that versus not having to deal with it. And we certainly go over this device in detail, describe it, and patients and families ultimately make the decision. I encourage my patients and families to try it for a month and see how it feels and if they're on the fence. Many will say they don't want to bother, but if they're willing to think about it, to give it a try for a month and see how it goes. And some will be willing to continue it, and others say it's too much of a nuisance or too much of a hassle. But it's important to talk about because it is an FDA-approved device, and it can complement our existing treatment approaches to help make them work better for our patients potentially.
Certainly. Thank you so much for explaining that so clearly, and thank you for providing an overview of the standard treatments that we have available for glioblastoma. We're also very much involved in trying to discover new therapies that will provide, additional benefit for our patients. And there are different modalities or categories that we're studying. I was wondering if, to start, you could just provide an overview of what are the different approaches to therapy that we're studying as part of clinical trials to advance the care of glioblastoma.
Yeah, this is, I think, a very exciting area, Nick, that we've been involved with at the Center for Neuro-Oncology at the Dana-Farber for many years. But the investigational or evaluation of promising new treatments ultimately derives from research being done in the laboratory to better understand what makes these tumors tick, what makes them aggressive, what may be Achilles heels we can try to exploit therapeutically. And that comes from the research that's ongoing, has been done and continues to be done. We started off, as I mentioned, identifying for the first time a chemotherapy that could make a difference in this disease. And indeed, a lot of research continues to work on identifying and developing chemotherapy-like drugs, or drugs that can poison cells that are trying to grow rapidly, like cancer cells, so have a preferential effect against cancer cells as opposed to normal cells in the body. These are treatments that don't discriminate good from bad, but they do discriminate cells that are growing rapidly. That's what chemotherapies focus on and hone in on and target. And certainly glioblastoma and many other brain tumors, cells are growing relatively rapidly and therefore preferentially affected by drugs that are trying to poison those cells, which is the mechanism of action of cytotoxic or chemotherapy drugs. So we're always trying to develop better drugs, more effective drugs, and ideally drugs that are not affected by, for example, the MGMT protein that you mentioned. Ideally, we'd like to find a drug that is agnostic to the MGMT component of the tumor and able to work just as well, regardless of that factor. And there's many good drugs that are being studied and tested with different mechanisms or strategies of trying to poison the tumor cells. But another important area that emerged as we understood the biology of these tumors and what makes them grow in such a dysregulated, aggressive way compared to normal cells in the body was the understanding that there are factors within the cells that are upregulated and dysregulated that give the cancer cells a growth advantage compared to normal cells in the body. It can also make them be more infiltrative and invasive. That gives them that capability of spreading out into the adjacent brain. can give them a benefit or an advantage of siphoning blood vessels to feed themselves over compared to normal areas of the brain. So these understandings of the factors that give tumor cells a growth advantage compared to normal cells led to the development of what we refer to as biologic or targeted therapies, where we now have treatments that can hone in on specific aspects, components of a tumor cell that do allow us to discriminate good from bad. These targeted therapies are very focused on, almost like a guided missile has been the analogy, on the tumor cell compared to normal cells in the body. And a number of biologic targeted therapies have been very important for many different types of cancer: lung cancer, colon cancer, breast cancer, et cetera. And we continue to work on, based on the research that's been done, understanding the factors that give brain cancer cells a growth advantage, targeted therapies against some of those factors that tumor cells are exploiting for their growth advantage. The trouble with a lot of these drugs, as well as the chemotherapy drugs, is what's called the blood-brain barrier. And Mother Nature designed our brain with an extra level of protection. And that protection comes in the blood vessels that are within the brain. And those blood vessels, unique to anywhere else in the body, has an extra level of insulation, if you will, of protection, where many molecules are not able to penetrate. And Mother Nature designed this very appropriately to try to protect the brain from things that could be harmful. And the blood-brain barrier ultimately is in place as a protective mechanism. Unfortunately, when we're trying to fight cancers that develop or spread to the brain, the blood-brain barrier can work against us. And many chemotherapies and these biologic targeted therapies are not able to effectively traverse that extra level of protection the blood-brain barrier provides, and they're excluded. In fact, the percentages are well over 90% of cancer drugs that are working in lung cancer and colon cancer and breast cancer and leukemia are not able to effectively penetrate into the brain. So that is somewhat of a handicap we have in our field to try to overcome, is to develop good therapies, but also therapies that can effectively traffic into the brain and get through the blood-brain barrier.
Thank you. You know, I know you're also very involved with the development of therapies activating the immune system to try to clear cancer cells from the brain. Can you give us a brief overview of how, you know, the immune system works in that fashion and how it can be stimulated to be more effective in that role?
Well, yeah, so you're referring, Nick, to immunotherapy treatments.
That's right.
And immunotherapy treatments are designed to take advantage of the natural defense system that Mother Nature designed in our bodies to protect us from anything foreign or harmful. And cancer should be in that category, one would expect. The immune system is fully capable of penetrating through the blood-brain barrier. We know when there's an infection in the brain, for example, the immune system is able to mobilize very effectively. So this is one treatment that one of the reasons I got very excited about immunotherapy is because for once we don't have to worry about the blood-brain barrier, and immunotherapy treatments, many of them, or treatments that can stimulate the immune system, will be able to effectively penetrate the blood-brain barrier and get into the brain, just like it would for any other cancer elsewhere in the body. Our natural defenses of the immune system consist of many different types of cells and many different types of components. I think a lot of what I was taught in medical school 30 years ago of how our immune system worked has evolved. And I know now what I was taught then, much of it is actually wrong. And we now know a much more sophisticated level of how the immune system works. And based on that ongoing research that helps us understand how the normal natural defenses of our body work, work has been ongoing to understand how cancers take advantage of physiologic components of our immune system in order to protect themselves. In other words, they have strategies that they upregulate and exploit that either turn the immune system off, deactivate it. They have strategies where they can hide and cloak themselves from the immune system. And they have strategies that they upregulate that can effectively exhaust the immune system where it can no longer be functional. So cancer is remarkable in many, many ways in terms of its adaptations to give itself an advantage over normal cells in the body. But one of the fascinating areas for me in our ongoing research is to better understand these mechanisms cancers utilize to evade the immune system. And some of the pioneering work that was done led to the development of a whole class of new cancer-fighting immunotherapy treatments by dissecting and understanding some of the fundamental principles of how cancers protect themselves from the immune system. And that's with the generation of what's called immune checkpoint molecules. Our immune system has natural, what we refer to as checkpoints. In other words, when our immune system activates to attack something that's harmful or foreign, Mother Nature designed that process to regulate itself and to turn itself off. Because if you think about it, if the immune system were to stay perpetually activated, that would cause harm and damage. So Mother Nature has a system, beautiful, intricate system, elegant system. Once the immune system has mobilized, attacked, removed the foreign threat, then it shuts itself off and turns itself off. Cancers have, many of them have the ability to block those normal checks and balances of our immune system. And by blocking the ability of suppressive of these molecules, they have the ability to turn the immune system off by upregulating these molecules that Mother Nature normally has to protect ourselves. Cancers can upregulate these molecules, including these important checkpoints called PD-1, PD-L1, CTLA-4. By upregulating these molecules, the tumor can effectively turn the immune system off and prevent it from attacking itself. And the basis and those discoveries of those molecules and the therapies that have subsequently been developed were the basis of the Nobel Prize that was awarded in medicine, I think in 2019, for understanding those mechanisms and now developing drugs that can block those checkpoints and take away that protective ability of cancers. And those drugs have revolutionized how we treat many cancers. Drugs like pembrolizumab or Keytruda, nivolumab or Opdivo, ipilimumab, these are drugs that are now approved across a spectrum of different cancers. And in many cases, they've replaced chemotherapy and radiation, kind of standard treatments for first-line treatment, how they can effectively treat patients. Unfortunately, although we've been involved heavily in the research involved in these mechanisms of action and the development of these drugs, brain cancer is more challenging and difficult, and simply blocking one of these checkpoints is not enough. And unfortunately, these drugs that have been so successful in other cancers have not been successful in many cancers, including brain cancer. And we need to be smarter. We need to figure out what other strategies the tumor is taking advantage of and what other drugs we could potentially combine these with to make them work more effectively.
Thank you so much for explaining that, David. And, related to that, I know you're very much involved in efforts to develop vaccines to try to target glioblastoma cells. So why don't you tell us a little more about your own work in that area? And also, there have been a number of other studies published, and patients often ask about cancer vaccines for glioblastoma. So just give us an overview.
Yeah. So vaccines represent one aspect of immunotherapy. There are many different aspects. I mentioned the checkpoint inhibitor drugs like pembrolizumab and Opdivo. Vaccines, another way to stimulate our body's natural defenses. And it's very analogous to a flu shot or a COVID shot. But here, instead of sensitizing the immune system against targets related to those infections, we're trying to sensitize the immune system against targets within tumors. And there are a variety of different strategies that have been tried and continue to be worked on. At the Dana-Farber, we've been working on a strategy pioneered by my colleague and collaborator, Kathy Wu, to identify the mutations that are unique to each patient's tumor, because every tumor, like every individual, has its own unique features. And by identifying the unique mutations to each patient's tumor, we can generate a vaccine that's unique to that individual patient's tumor. So it is a little different than the flu or the COVID shot, where one vaccine covers everybody. Here, we're individualizing it and tailoring it to be very specific for each individual patient. That platform we're working with at the Dana-Farber called NeoVax is utilizing that technology to identify what's unique and different. We do this in collaboration with the Broad Institute at MIT and many talented collaborators. It is something that we're excited about. We've seen very good immune responses the vaccine is able to generate in patients who've received the vaccine. And I think very importantly, what we're doing now is trying to combine the vaccine with other therapeutic approaches that could make it work even better. For example, we know these checkpoints that tumors upregulate to protect themselves. If we give the vaccine by itself, it's probably not enough. If we give the checkpoint by itself, it's probably not enough. Putting the two of them together offers another complementary combinatorial approach where that's our current research focus now, and where we hope we'll be able to get better results. But the research and the work continues, and vaccines are one strategy, but there are many other strategies our group and others are working on, trying to tap into the potential of the immune system to fight brain cancer. It's been remarkably successful in many types of cancer. I think if we persevere and continue our research and work, we'll be able to achieve a level of success and benefit for brain cancer patients as well.
Thank you so much. Very interesting and very promising. I think we're all very excited about these studies, and our patients are very hopeful of seeing a good response with them. I would like to take the next 15 minutes or so to answer questions from our audience, and some have already been submitted. If you want to submit questions, you can do so through the Q&A feature here at the bottom of the screen. I remind you, as we noticed at the beginning, we are providing general information, so we cannot provide specialized advice. But if you're interested in, getting a second opinion or discussing your case, your specific case with one of us, we encourage you to seek a consultation. But I'll dive right in here, and we'll receive some of your questions via email, so I'll try to get to those too as well. One of the viewers asked a question about radiation exposure, and the viewer is asking, would exposure to high doses of radiation from a nuclear plant accident be possibly related to an increased risk of glioblastoma or low-grade gliomas?
So yes, higher doses of radiation, accidental exposure, like a nuclear fallout, could increase the risk of many types of cancers. That type of a radiation exposure to an individual would probably most acutely threaten their bone marrow, the ability, the area of the body that produces blood cells. And unfortunately, patients would likely die from complications related to bone marrow failure before they died of or had chance to develop a brain tumor or other type of solid tumor in the body. But yes, that type of radiation exposure from a catastrophe accident like that could lead to an increased frequency of many different types of cancers, including brain cancer.
Thank you. There's a question about one of our conventional therapies, the alkylating chemotherapy, lomustine. So a patient is asking, or a viewer is asking, how many times can I receive lomustine over the course of my disease. And we can discuss a little bit what are the limitations with patients receiving lomustine and what are the things that might make us stop at the administration of that medication.
Yeah, one of the things about all of these therapies is every patient is different, and how they handle a given treatment, the side effects they have may be very different. And sometimes it goes along with age, and older patients can have more difficulty, but not always. I have patients well into their 70s who have tolerated therapy very well, and then patients in their 30s or 40s who've had more difficulty and trouble. So everybody's different, and part of what helps make a difference for our patients and families is having a very good team of skilled and experienced individuals, our nurses, our nurse practitioners, mid-levels, physicians, everybody working together to understand and to work closely with each patient and family on a unique basis, because they are so different, and how any given patient would do with a given treatment can vary considerably. That being said, lomustine is a chemotherapy drug that does penetrate into the brain, so it has a track record of benefit for patients with brain cancer. But it is one that tends to have more side effects than, say, temozolomide or Temodar, and particularly on the blood. And those side effects tend to be cumulative, where the more doses a patient has over time, the more side effects can happen. And at some point, we have to either cut the dose or stop the treatment in order to try to avoid an irreparable or irreversible side effect, particularly on the blood. And some of my patients, that can happen after 3 or 4, 5 doses of lomustine. Some we can start to see signs of it after even 1 or 2. So it really varies quite a bit from patient to patient, and your team will be the best people to guide you on what is safest and most appropriate for how many doses potentially for you to receive.
Thank you for explaining that. Yes, it's certainly a therapy we use often, but it has limitations sometimes in how patients tolerate it. We hear from a viewer now that talks about being diagnosed with glioblastoma approximately 8 years ago, and for the last 2 years, suffering from ongoing dizziness. And this viewer is asking if this could be related to chemotherapy or radiation. So it's a question of developing dizziness after treatment. Is this something that you've seen in your patients?
Certainly, sensitivity to position, dizziness, sudden movements can be a longer term side effect or sequelae that can happen after the tumor has been present, after surgery, after radiation and chemotherapy. All of those things together can contribute in an additive way of symptoms that can develop. And in some of our patients, it can be headaches. In some, it can be a risk of seizures from chronic inflammation. In some, it can be dizziness or sensitivity to position. It can vary quite a bit. It depends somewhat on the anatomy and what part of the brain was affected. And remember, this all started from the tumor, and the tumor causing damage and infiltrating into the brain. Treatment, in addition to the tumor, can have longer term side effects over time. I think one of the other attractive features of, say, for example, immunotherapy, and my hope and dream in my career would be at some point we'd be able to use immunotherapy sufficiently successfully where we could avoid radiation and chemotherapy and not have to expose patients to these treatments, which, although we know help, have long-term as well as short-term side effects. And immunotherapy treatments, tapping into the potential of our natural defense systems, although they can have side effects too, don't get me wrong, may be advantageous and hopefully allow us to avoid some of the side effects. We want our patients to survive these tumors, but we also want them to be able to live well and maintain as much functional capacity as possible with minimal side effects.
Thank you. There's another question coming that is related to symptoms. Why are brain cancer patients prone to focal seizures after tumor resection?
Seizures, I think of them as an analogy of kind of like a short circuiting, if you will, at home. If you're looking at your fuse box or electrical circuits in your home, if there's some damage, if there's overactivity, if there's water content, there can be a short circuiting that happens in that area. And that's actually a pretty good analogy for what can happen when a seizure happens in the brain. There's abnormal electrical activity that happens in that area of the brain, and it often is linked with inflammation that can be triggered from the tumor or the treatment. And that abnormal electrical activity can cause some temporary dysfunction in that area of the brain. So if that area is affected and it's limited to that area, patients can experience what we call a focal or a localized seizure, where they may have twitching on one side of the mouth, or they may have loss of sensation in one part of the body, or even temporarily difficulty articulating and speaking properly. It just depends on the anatomical area the short circuiting is happening. And although those are frustrating and unpleasant experiences to go through, what we worry most about is if that short circuiting that's localized in a given area spreads and involves the whole brain or most of the brain. And that's when a patient can experience a generalized seizure, where a short circuiting effectively shuts down the entire brain for a period of time. And those are potentially ones that could be more harmful and even potentially could affect the areas of the brain that regulate our breathing and heart rate and blood pressure, and cause complications or even death from that being involved. So a localized or focal seizure, to me, is always a red flag that we need to treat or be able to better control, not only to minimize the symptoms associated with that localized malfunction, if you will, but to try to prevent the more serious generalized seizure from happening. And Nick, please, you're as a bona fide board certified neurologist, elaborate on anything that I commented on there.
No, I agree 100%, and I think that's a very good analogy that you use. It's the brain is an electrical organ, and the electrical activity of the brain is disrupted by the tumor and often by the treatments that we provide to our patients. And that abnormal electrical activity can sometimes lead to symptoms and generalize, leading to loss of consciousness. So that's why it is so common for our patients to experience seizures, and why we're so vigilant of symptoms, and we try to treat so aggressively, because it's not only about tumor control, it's about also good quality of life and making sure that patients are not having seizures that prevent them from engaging in their normal activities. We receive a question about the survivin vaccine, and the question is about combining that vaccine with other treatments. And what are your thoughts on that particular study that was recently published, highlighting the response to that glioblastoma treatment?
Yeah, the survivin vaccine, although it has led to an improvement in survival for patients in the trials that's been done, it's actually named for a molecule that's upregulated. And again, research identified this molecule to be upregulated in several different types of cancers, but in particular in glioblastoma tumors, called survivin. And this molecule that was identified does contribute to giving the cancer cells a growth advantage and a survival advantage. With the identification of that molecule, people began to wonder if they could take advantage of that knowledge and that information to block that, or to have a therapeutic effect against it. And one strategy developed by Rob Fenstermaker, who's the chair of neurosurgery at Roswell Park in Buffalo, was to try to develop a vaccine against it. And he set up this research effort many, many years ago to develop a vaccine against this target. because it is upregulated uniquely in cancer cells and could therefore be exploited. Unlike the vaccine that I talked about, where we're utilizing many different targets within the tumor, the Survivin is really specifically focused on one target. But he worked on this for many years and came up with a very elegant strategy with this vaccine, ultimately, that when administered to patients, initially in the time of recurrence, but most recently in a randomized clinical trial in newly diagnosed patients where it was combined after radiation with chemotherapy. The patients who got the vaccine not only showed good responses when their immune system blood tests were evaluated, but patients who got the vaccine as opposed to placebo tended to live longer and in a fairly notable way. Again, not a home run curatively for patients, but there was a significant benefit. And the other important aspect of this is the vaccine has been shown to be very safe and really with little to no side effects. So we're very excited about this as a breakthrough because it does provide precedent that the immunotherapy treatments tapping into the potential of our body's natural defense system may be able to have a benefit and make a difference. And in general, supports the lower likelihood of side effect or toxicity potential of these treatments as well.
Thank you. Yes, no, very exciting. And we have a study open here at our center, and I have noticed the same thing, at least that our patients tolerated very well. There are a number of questions that are coming through about how to optimize your routine and your activities outside the clinic to maintain overall health, including nutrition and exercise. And we don't have time to get into them today, but I strongly encourage you to join our additional webinars where we're going to be dealing with a lot of these topics. I'm going to do a short series on exercise for brain tumor patients coming up in a few months, and you'll get more information about that. So I just posted our survey on the chat here. So if you take a minute to complete that survey, we'll get useful information, learn more about what topics you would like us to discuss, and then we'll also add you to our email list. And our colleagues on the Blum Center who are hosting our webinar today will be posting another survey as well, just to comment on the format and how things are being run. But I want to take one last minute to thank you, David, so much for taking the time to join us today and to provide a very detailed and clear overview of glioblastoma, the challenges in its treatment, and highlighting some very exciting therapies that you and other colleagues here at the Center for Neuro-Oncology are helping develop. Thank you so much.
My pleasure. Thank you for organizing all of this, and thank you for everybody for attending. I'm so glad to hear that you will be having upcoming sessions focusing on nutrition and exercise and stress and getting good rest, because those critical factors of a healthy lifestyle are so important to our patients and help contribute to their immune system staying strong to help us fight the tumor. So those will be very helpful and very important to go over and to discuss in an upcoming webinar. So really glad to hear that, Nick. And thank you again for organizing all of this. And my pleasure to contribute.
Absolutely.
Thank you so much. This was a really great webinar, and I'm glad that we have this series. And if you do want to catch up, I know we've only had one other so far, you can check out our YouTube playlist and our Digital Resource Center. So thank you all again and have a great day.
Thank you all. We'll see you next month. Bye-bye.
Thank you.